So I saw somebody made up their own post of an old one, but a good one. I've never met a flat foot that a hip couldn't fix. And that is something that I significantly believe, even when the foot is significantly rigid. Except what these people put in their post was they left the flat foot out. So look, there's a lot of hip issues that have nothing to do with the foot. There's a lot of foot issues that have nothing to do with the hip. To suggest that all foot limitations or conditions have something to do, that's false. However, I do have a significant opinion that most flat feet, if you can, even in the open chain planar flex, you can see an arch. There's no reason that that arch can't live in the closed chain. If you can get up onto your toes, there's some level of arch. If you can get up your toes and walk, there's some degree of arch that can live in the closed chain in other positions. Doesn't only have to be planar flex. Those are the ones that the hip can have significant impact on. So even if it's not a huge change in the arch, I think that's very, very real. Now, when your foot is on the ground, and let's just say you tighten your bottom, this actually happened to me years ago, where I was like, first of all, one of the best seminars I've ever taken in my career was when the old RKC, it might have been their first or second iteration of club swinging. It was in Minnesota, which was always the headquarters. It wasn't in that little, preschool gym. It was in one of the convention centers. Brilliant course. So I'm like in the second row, back right, and I'm pretty sure it was Jeff O'Connor who wound up. That's where I met him. That's where he wound up doing the RKC at Marsoc for us because Pavel couldn't come. I'm just standing there listening, and I probably had my feet buckled in. And he's like, "Charlie, you have flat feet." And I'm like, "No, I don't." And he goes, "Really?" I said, "Yes." And I tightened my bottom, and my feet got into this really solid short foot position. And then he just shakes his head because I'm pretty sure he did not think I had flat feet. It was just messing with me. So what happened right there? What happened when I just tightened my bottom and all of a sudden my feet looked like they had a very, very nice arch, very, very short foot. My foot was very small to begin with. Still squatted 800, by the way. So think of the kinesiology of the glute max. And it's very, very keen that you'll see if you lift your foot like a little bit off the ground, you shift off, tighten your bottom, your foot will externally rotate. Well, how do you externally rotate, or what happens when you externally rotate and that chain is closed? There is an action of supination, of which external rotation is one component, and you load the lateral calcaneus a little bit more than the medial calcaneus. You load the metatarsals a little bit more laterally, but you maintain the first med head as well on that sesamoid bone. And your arch winds up lifting up. It's like your foot kind of goes like this, and it goes like this, and gives yourself a little arch. Now, in that case, if you don't see a significant change, we might want to look at the navicular and see that arch will start to become, whether it's a spring ligament, whether it's, let's call it hallux, abductor, I'm pretty sure that would be a brevis, that these are all components that can be mitigating the joint motion, even though the moment of external rotation through the hip is happening. Now, if that is not a normal motor strategy to have hip extension in the closed chain, the foot's going to drop. And that consequence of the foot dropping can lead to hallux valgus. It can lead to that more chronic rigid flat foot. It can lead to tibial internal rotation. It can lead to knee valgus, and it can lead to hip internal rotation. It can lead to, and it already is a part of some form, well, I guess it doesn't have to be, but typically you'd see some type of pelvic anterior tilt. And look, you're not going to bait me into saying it's the lower cross syndrome, but there's nothing wrong with just using the terminology lower cross syndrome to describe some type of construct where the pelvis is chosen to remain in that dumped up position, where it becomes a little bit more challenging to regularly create that external rotation moment through the backside of the hip. I think as it relates to the lower cross syndrome, even way back when, nobody said you had to have all four. Like, lower cross syndrome was just a position, and it didn't always have to have very, very tight hip flexors that when the chain closed, it threw you forward. And it wasn't this deviant or inefficient motor strategy where you couldn't pressurize the lower abs or even tighten your bottom. It could be any combination of those four, as well as the tension of spine, the tension lower back. It could be 3 out of 4, it could be 2 out of 4, it could be 1 out of 4. And if that 1 out of 4 was so prominent, then you did have lower cross syndrome. So it certainly exists. It's just not as linear, certainly not a linear solution in any way, shape, or form, because you could be going up and down and then changing how the chain is closed distally. All of a sudden you're on your knees, and all of a sudden these things change because there is an issue at the foot driving it north. Okay, so now you start to see there's a lot of connection here between the hip and the more supple but certainly same rigid. Look, if the foot is so rigid, then again we're going to mobilize, and then the hip still has to create that external rotation moment. So it doesn't always even have to be the navicular. We could look at the first cuneiform, you could look at the first ray. Lesser degree for this type of motor strategy would be second cuneiform, third cuneiform, and the cuboid. They're all players, and they all have a manual therapy. There's a self-mobilization that you can use on a half foam roller, and we actually did, I believe, I'm not sure, I don't remember if we filmed that for the exercise library that'll be available over the next couple months. But then there's also proprioception and awareness, which is really another word or category of seminar where you can call it LDOA for the foot. So not only are there LDOA, because it's probably not the best term to call LDOA of the foot, because there's also lots of ligaments and soft tissues that can be fascially tensioned, not just bones or joints. So regardless, if there is a reason that the flat foot is more rigid than you prefer, you mobilize it and you treat it the same way you would other joints, and then you would follow it up with some type of fascial exercise. And then in this case, there may be a little bit faster than a 4x4 matrix, but it's the same model. You treat, you follow up with the fascial technique, and then you go into motor skill acquisition, whether it's mobility or skills. So you don't change, especially if you can't get that navicular to roll. And that's the navicular. If I have a handle on it, and there's a rock here from the backyard, it'll go like this. So my foot is here, my big toe is here, and then I'm trying to get the navicular this way. And if that's not happening, then okay, then maybe the hip isn't going to be powerful enough. But if the hip is powerful enough and you're strong enough through your foot, you can use the lower body connection there, the motor skill connection, to mobilize the navicular, and that can happen. So the correct quote was, "I've never met a flat foot that the hip couldn't fix." That post, I'm sorry if you're watching this, I couldn't retweet it or share it because it wasn't the correct quote, and I'm not sure I would be as linear on the language in the copy. So hopefully that all makes sense. The correct quote: "I've never met a flat foot that the hip couldn't fix."